Anyways, my name is Luke Todd. It's a pleasure to be with you this morning. I know I've met several of you on meetings like this or in other situations, but if it's my first time being with you, yeah, thanks for being here to look at mobile crisis intervention services and stabilization services billing guidance. This is the second of two TA sessions that we had planned as this guidance was coming out. We didn't have the guide published before the first one. So hopefully this one will run a little bit more smoothly with you all having access to it as we go through. This obviously won't be the last of these that we hold necessarily. It's just the last one that's currently scheduled, but we know questions will continue to come in as we go, and we'll continue to support you all as you work on standing up the new service. So anyways, I'm a behavioral health policy analyst from the Medicaid programs unit, and yeah, excited to get the billing guide out to you all and keep moving forward with this. So Brian, if you can go to the next slide, we can jump in. The presentation here is, it's very similar to the content you'll see on the billing guide, but it's not quite as comprehensive. It doesn't have every word or every relevant criteria there. So as you are, developing your policies and procedures and your understanding of the billing requirements, please make sure you refer to the actual billing guide and FAQ. Not just to this presentation. It's not meant to be comprehensive in that way. Excuse me. And then, as you all know, administrative rules and sub-regulatory guidance is always subject to change. So my plan is to keep the billing guide as is for a while and to make necessary updates by adding additional questions to the FAQ document. So you'll see that one probably refreshed on a more regular basis. Again, if anything comes up that we need to change in the billing guide, we'll make sure to do that and to communicate that as best we can. But as always, just make sure you're referring to the most up-to-date guidance that you can. Next slide. Oh, and before we jump in, I'll just say, if you have any questions along the way, feel free to put them in the chat. Feel free to raise your hand. We'll just be pretty informal here. There's a chance if you ask a question, I might defer it until later in the presentation, or if it's for a different team, if it's, say, a certification or program question, I may, we may need to hold it until and answer it another time for you. But yeah, feel free to put questions in the chat or raise your hand as we're walking through things. So reimbursement rates for our mobile crisis services. I want to highlight before I get to the rates themselves, just that these rates that you see here are based on the service rendered, not on the number of providers rendering the service. So if a team goes out and provides mobile crisis, whether it's old standard mobile crisis or MCIS, which is the new standard that we were working on standing up, you're only going to submit one claim, not one per team member, right? It's a question that came up in a prior session along these lines. And yeah, we just want to make sure you all know it's the rates and claims should be per service, not per team member. So the rates themselves, for both services, you're going to use the procedure code H2011. With the CG modifier is what you'll use for old standard mobile crisis, and that will pay at kind of your basic H2011 rate of $39 per 15 minutes. For MCIS, or Mobile Crisis Intervention Services, the new standard, you'll use the HE modifier, and that's a pricing modifier. When you use that, it will pay out at $105.57 per 15 minutes. Next slide, Brian. So just a quick note on certification and mobile crisis intervention teams. CMHPs should have heard from our licensing and certification department around a new application to add MCIS and stabilization services to your certificate of approval. And yeah, so you just need to have that certification process, go through that certification process before you can bill for MCIS. And again, if you have any questions on that, happy to connect you with the right folks. In terms of the team piece, the initial crisis response, and I'll get to a definition of initial crisis response very soon. The initial crisis response must be rendered by a mobile crisis intervention team. You can see the rule reference there where that's defined. So the initial crisis response must be rendered by a mobile crisis intervention team. Follow-up responses can be rendered either by an MCIT or by one person, but only MCIT responses are paid at the MCIS rate of $105 per 15 minutes. Got a little asterisk there because there is one exception that I'll get to a little bit later, but just by way of kind of the general framework of things, you always need that two-person team for the initial crisis response. Follow-up responses, it could be a team or one person, but there is going to be a difference in pay depending on who responds, whether it's a team or one person for that follow-up. I don't see any hands raised, but Beth, if you see any questions come in the chat, let me know, just because I might miss them. But yeah, we can move on to the next slide if there are no questions right at the moment. All right, so again, another piece with mobile crisis intervention services that's new compared to the old standard mobile crisis is that there's a sort of a 72-hour window in which you can render MCIS. So in that 72 hours, we're pegging to the beginning of the initial crisis response. And here's the definition that we've come up with for that. The initial crisis response is when an MCIT responds to an individual experiencing a behavioral health crisis from the time the MCIT arrives on scene or first makes contact with the individual, whichever is earlier, until the MCIT leaves the scene. So that's kind of like what's going to set out the just the basic 72-hour window. Another question we had was, what happens if another, so that 72-hour window might end, and like 5 days later, you might have another initial crisis response that's needed. A 72-hour window is going to start again. The same thing could happen on hour 50, even within the initial crisis response, or not, sorry, within the initial 72-hour period. And so regardless of when that happens, if another initial crisis response is needed, that 72-hour window will begin again. And I saw Stacy's hand.
Yeah.
So let's go to Stacy first.
Stacy and then Shelley.
Great.
Hello, thank you. So mine actually was on the previous slide. Having a hard time with all my windows. So if just to be clear, so you have a mobile crisis team of 2 people going on the crisis, but then our follow-up plan is a phone call. Even if one person's making the phone call, even if they're part of the MCIT team, it's not an MCIT service.
It's a great question. When I have a follow-up slide where I'll talk a little bit more in depth about how the follow-up will work, there is, when we think MCIT, we are thinking of like the 2-person, like at least 2 people engaged in the response. There is a scenario that I'll talk about later where a 1-person follow-up, for instance, somebody calling to follow up, can still pay at the higher rate of $105 per 15 minutes. It just depends on who responded in the initial crisis response.
Okay.
So we'll talk more on that a little bit later. And if it's not clear at that point, let me know. And
Okay, thank you.
hopefully as we keep walking, it'll clarify a little bit.
Shelley?
So Beth, this kind of goes back to yesterday. Maybe it'll be answered in the follow-up slide, because I'm struggling wrapping my mind around the 72 hours. So we respond to the initial crisis in the community, and then we do our follow-up services, and those can go on, we follow up, the next day and up to 30 days normally. But we usually switch to outpatient codes. So can we still use crisis codes for that initial 72 hours and the follow-up codes for that, and that's considered follow-up? I'm just struggling wrapping my mind around the 72 hours, and because it's not a crisis when we go back out, we're usually following up from the crisis.
Yeah. So I'll say one thing, and then I think
it'll be addressed in the next slides. Okay.
Yeah, we'll talk follow-up services and stabilization services.
Okay.
And so you just let me know as we continue on what we need to do.
Okay. Sorry, I'm just struggling with that.
Totally.
Yeah.
So hopefully as we walk through, it'll clarify a little bit, but I'm assuming we'll have more to talk about after we've gotten through all the material. So excuse me. Yeah, I may have said that I was going to answer something like right now, but I think I'm just going to keep walking and then we'll come back to, I'll just get your questions again at that point, whatever's left over. Let's see. All right, Brian, I think we can move on from this particular slide and go to the next one. All right. So just kind of these are basic billing criteria for MCIS. As we said, you're going to use H2011 with the HE modifier. And that right there is all you need to get the $105 per 15 minutes rate. Just H2011 with the HE modifier. You're going to do that, of course, after you've been certified for MCIS and when you're rendering MCIS according to rule. In terms of the HT modifier, you're going to use that when the following three things are true. The HE modifier has been used, meaning we've already checked that box. So if that's the case, and a QMHP participated in the duration of the response, and that could be either as part of the MCIT providing in-person response, or it could be via telehealth. But regardless of which of those two, they have to participate in the duration of that initial crisis response. And the other piece, the response took place outside a hospital or facility setting. So if all three of those things are true, you'd add the HT modifier. Doesn't change what you get paid at all. This has to do with the community-based mobile crisis intervention services that was added through the American Rescue Plan as a new covered service by CMS. And when you indicate that you've delivered services at that level, it changes the way we claim federal match from the federal government. Go ahead, Anne Marie.
Hi, this is actually for Beth. Beth, when we had talked earlier, we had said it had to be a QMHP responding. So this is the first time I've seen telehealth as an option for the QMHP. I'm really clear the QMHP has to be part of the team in order to bill at the higher rate, but telehealth counts now, is that right? Because that seems new.
Yeah, Anne Marie, I will say that we've gone back and forth for the last 2 years, but the final from Medicaid guidance is that long as a QMHP is available and available to, and doesn't have to physically be part of the two-person team and can actually be available to do a mental health assessment if need be via telehealth, knowing that that's not going to work for everybody. Sometimes, the QMHP is going to have to be on site to do that assessment.
Absolutely.
Because not everybody
Absolutely.
engages. I mean, we talked about what are the odds of a teenager being able to do a telehealth. You know what I mean? Like,
Yeah.
So it is true that they do include telehealth now in this.
I actually am going to say thank you for that, because I think everybody on this thing can tell you how hard it has been to try and hire QMHPs into the crisis services. So thank you for that. One
Yes.
follow-up question. If the team goes out and they find that the person really needs a face-to-face eval, will we still be able to bill at the higher rate if we bring them back to a 24/7 crisis center for the follow-up eval?
That one is a Luke question. That's a facility versus that, so I can't answer that, but Luke.
Yeah, Anne-Marie, can you tell me a little bit more about the facility that you're talking about bringing them back to?
Our psychiatric crisis center is a walk-in crisis clinic. It's 24/7, and we have QMHPs around the clock with bachelor's level skills trainers and security, and we have prescribing services for soon to be 5 days a week, where we can do follow-up with prescribers after the crisis intervention. So I'm talking, the team goes out in the community, they're doing the crisis intervention, maybe they tried telehealth, but this person is not engaging well, but they agree to come back to the crisis center. And it's a walk-in clinic, so it's first come, first serve. Our average wait is about 25 minutes, and they come in and see the crisis screener for evaluation. Will that count as MCIS? Because we did go out in the field to start.
Yeah, would the QMHPs at the crisis center be part of your MCIT and have all the same like, are they the same? Is it the same QMHP that would be available via accessible via telehealth if needed?
They would be the one who would be doing the telehealth. Yes, they would be doing the person responding by telehealth. And then if the person just really, our goal is to not bring people back to the crisis
Sure.
center, but if they need that level of care or they need that level of safety,
Mhm.
then we want that to be available to them.
Yeah, I'm gonna think on that one. I'll give you my initial impression, but I'll work on getting a more certain answer for you. In my mind, that would make sense, providing it's like for someone to be a QMHP that meets the criteria in rule, they obviously have to have all the same training that's outlined, required for the mobile crisis staff.
We are training the entire QMHP
yeah.
staff to be MCIT or MCIS trained. So yeah.
Yeah, and so I think given that it is a mobile crisis response, and then you're working on continuing to provide whatever services and assessments are needed, I would think that it would still be billable under that. But I will just hold that kind of loosely, and I'll get a final response for you one way or the other. But I appreciate the question.
I can put my email in the chat so you could respond later.
That'd be great. Thank you.
Thank you.
I got Anne Marie's email. I'll make sure we follow up with you, but yes, please put it in there so we don't forget.
Thank
Luke,
you very much.
Yeah, I know that this comes up and I know you have some guidance, but can you explain when asked, does outside of a hospital facility mean that you are physically standing outside of that facility? So like say somebody, if MC could, what considered to help, obviously to help avoid an admission. So say the MCIS team is in the parking lot of the jail or in the parking lot of the hospital. That's still an MCIS response because it's outside and they're not admitted into the hospital, correct?
Yeah, so I appreciate the question. It's not intended to say that you have to be directly outside of one of those locations. It just means not in. So I recognize the confusing wording there and appreciate the clarification. Yeah, so it's just saying the response did not take place in a hospital or facility setting. That's the criteria for HT.
And then we have Amory's. Thank you. Hopefully, when was that? Does that clarify? Hopefully, if not, you can unmute and ask a follow-up question. I think that's probably.
I think so. Yep. Thank you.
Okay, thanks. We are trying, I am thinking about, we are trying everything we can to possibly keep people from being admitted to the hospital unless they need that level of care. So if you guys are intervening, we also had a question about pre-booking, what if you're in the lobby and the person's not booked yet? Once they're enrolled, once they're admitted or they are in jail, that's, or the hospital. So there is sort of a gray area that Luke explains in the guidance too, but.
Yeah, and Beth, that's one in particular that I haven't gotten a final answer on yet, but I will make sure that's added to the FAQ once we do that. The hospital and facility setting is specific to using that HT modifier, and it is specific about the location where the response takes place. The question of pre-booking at the jail issue is not about the location, and it's not about whether you use the HT modifier. That's about folks that have been incarcerated losing their Medicaid eligibility. So that one's a little trickier and a little bit of a different question. So yeah, we'll have to get follow up on that particular question as well. But the two are, it's easy to think of them as the same thing, but they really are apples and oranges. So any other questions from the chat before we move on? I do see one from the chat, Beth, that it says, let's see, can a team service be provided if none of the team members are a QMHP or higher? And just that you'll see that in rule in that the MCIT can be a QMHA and a peer, for example, and there has to be a QMHP available if needed, but the QMHP does not have to be on the team for you to be rendering MCIS and bill at that higher rate. So if you HT and use that modifier, then you would have to have a QMHP actually participating for the duration of the response. So in one sense, all of these questions depend on which modifier we're talking about. Again, I think the HE modifier, which is the one that gets you the higher rate, is the one that you all want to be thinking about is kind of like that's the fundamental level of service. The HT one, again, is you just saying, hey, in this particular instance, we delivered a service that was not in a hospital or facility. A QMHP was engaged in the duration of the response, and we used the HE modifier.
So Luke, just to clarify back to Anne Marie, can we give, can I just give a scenario just so that we're all
Yeah,
on the
absolutely.
same page? Is if we get a call from, if mobile crisis is asked to come out for a call and they send 2 people and both of those people have all their trainings, they're qualified, they're under a certified, if it's 2 QMHAs, but they have access to a QMHP on call and they go out and say they de-escalate the situation and it doesn't require them to get the QMHP involved,
Mhm.
do they get the higher rate?
Yep.
Yes.
Yep.
And if they do need the QMHP to assess the person and they're able to safely do that using telehealth, that QMHP can engage with the person in crisis and do the QMHP level assessment if they can do it either by telehealth, that counts, or that QMHP has to be able to go to the scene or go to complete the assessment in person if they're not able to do it in telehealth, correct?
Yep.
Okay, I just wanted to make sure.
Yeah. I see another question in the chat from Andrea. What is the difference between the HT and HE modifier? Brian, I don't know if you want to roll back up to, actually, I don't have this slide that has that one. Let's just leave it here then. So yeah, HE is your pricing modifier, and that essentially when we see H2011 HE, we see you're telling us that you are rendering mobile crisis intervention services. That's the new rule set 309072. And that's saying you're raising your hand, we're certified, we're rendering the service according to rule, pay us the higher rate, right? So again, that's on you all to like get to know that rule set and adjust your service delivery accordingly. So that HE rate or HE modifier is your pricing modifier, that gets you $105 per 15 minutes. HT is just an informational modifier. It helps the agency. And when the HT modifier is used, it means there's another layer on top of what the service that's described in rule. Essentially, it's saying, not only are we doing MCIS as described in rule, we also had a QMHP for the duration of the response, and the response took place in a community-based setting. And those two things are connected to, again, the American Rescue Plan Act, where they set out community-based mobile crisis intervention services as a newly covered service. And for the first 5 years of that service, it's eligible for not 5 years, three years, I think, for an enhanced federal matching percentage. So again, that's the difference between those two are HE is your pricing modifier, that gets you the higher rate. HT is an informational modifier that tells the agency something and impacts how we bill or how we do our federal claiming with Medicaid.
Luke, I know this one is really complicated too, but are the CCOs going to be using the same modifiers, and will that be consistent, or is all of this just for OHP fee for service?
Yeah, so I'll say that the billing guide that's just been published says on the front that it's a fee for service billing guide. So as of now, that's what is official. I know the plan is, and I would say it's tentative until it becomes final. But the tentative plan is that CCOs, or that you will bill for fee for service and CCO members in the same way. So I think they're sorting out CCO capitation rates and how it impacts CMHP funding and all those pieces. And there's a lot there that I'm learning about as I watch it happen for the first time. But with that, the intent is that billing would be the same for all Medicaid populations, regardless of whether they are fee for service or CCO members.
And then for private insurance, a lot of the agencies are not able to bill private insurance because private insurance, has different requirements. So Monroe was just saying these rules make it extremely difficult to bill a patient's commercial insurance. are you familiar with any with the commercial insurance side of things?
Yeah, as far as I understand it, and this is again maybe where my knowledge runs out, but I don't know that these, and maybe the reference is to the administrative rules and not to the billing guide, because the billing guide here is just for how to bill Medicaid members. So if it's possible to bill a patient's private insurance or commercial insurance, that information would come from them on how to bill if they have a behavioral health crisis. I don't think this billing guide would impact that at all, except where it offers any clarity on the actual service itself compared to the rule. So
Correct. And most of our CMHPs who are responsible for providing mobile crisis, my understanding is that a lot of the CMHPs do not have ability to bill private insurance, which is why we are also giving general funds to help offset some of those costs and working on other legislation to be able to make that possible. So.
all right, I think we can move to the next slide, Brian. All right, so mobile crisis intervention services follow-up response. Again, I gave you the definition earlier of the initial crisis response. Here's an explanation for the follow-up response. Any MCIS rendered after the end of the initial crisis response is a follow-up response, and it's going to be billed in the exact same way. The same slide that we just walked through about HE and HT, that all applies for a follow-up response. And here's the one exception that I referenced before. One-person follow-up responses are allowed under rule, but they must be billed with H2011 CG. Again, that's the CG modifier. If you remember back to an earlier slide, is the one that indicates the $39 per 15 minutes rate. And the unless here is that if the initial crisis response qualified to use both the HE and HT modifiers, then you would use HE for one-person follow-up. And if the follow-up response also took place outside a hospital or facility setting, you would use HT as well. I realize this is convoluted. There is, Brian, I might ask, I don't know if you have this ability to drop the presentation for a minute, but on the billing guide itself, I guess you all have, I put the link to the billing guide. Brian, why don't you just keep it here? But in the billing guide itself, down at the end, there's an appendix with a sort of question and answer tool, like a decision tree, that will walk you through a given crisis response to help you determine which modifiers to use. So there's 2 questions for the initial crisis response and then 3 for the follow-up response, just to make sure you can walk through a given response and know how to code it. So if you all either look at it right now or go check it out later, but that tool is designed to break it down to the simple, most discrete, like kind of items that will help you determine in a given response which modifiers to use. Shelley?
Luke, oh,
Go ahead, Beth.
Go ahead, Beth.
I was going to read the, if it's about what he just said, go ahead. I was going to read the questions. We got a couple of questions in there.
Well, and maybe I haven't read the questions. Maybe it's in my, because I'm just trying to look. So the H2011 with the CG will be considered a follow-up code. But maybe I missed if it's like response, because I'm thinking, so I think I clearly understood there's mobile crisis and then there's hospital response. Ooh, the screen just left. So the mobile crisis, it has HE, HT modifiers. That was very clear. The hospital follow-up with the H2011, they see them in the hospital. Is there a modifier on that? Because it's just a single rate. The 39.05 is what I'm gathering.
Yeah, and the 39 is not specific to a follow rate. That's if you do one-person follow-up.
One person, because I'm just trying to figure out. So it's clear here the H2011 with the CG would be the follow-up.
Well, it's so I'll just say it this way.
Okay, please.
The rules require mobile crisis intervention teams to do a follow-up or to attempt a follow-up response within 72 hours. If say the team goes out and it's like 2 QMHAs, they go out, they do the thing and it qualifies, they use the HE modifier, they're paid at the $105 rate. If 2 days later, they go and see the person at their home for an hour and it's still the same 2-person team, even though it's follow-up and not the initial crisis response, they're still paid at the $105 per 15 minutes rate.
That makes perfect sense to me,
Right,
but
okay.
we do a lot of stuff at the hospital.
Gotcha.
I mean, we do
And-
tons at the hospital. So that's
Gotcha.
where I'm trying to clear. I think it was
Perfect.
actually in my brain, I got it fairly clear from the initial stuff. I still don't know how you're going to separate out what's follow-up versus what's the initial codes. I still, maybe that's what I'm trying to figure out. How are you going to figure out what's follow-up and what's initial service? Because maybe that's my question.
Sure, and I'll just say, Beth, before you jump in, there is not a distinguisher in the way this is coded that will tell us, just by way of the procedure code and modifiers used, whether it is the initial crisis response or a follow-up response, because it's all mobile crisis intervention services, and the rate is for mobile crisis intervention services.
Okay, because that's where we have an APM or a, with our CCOs, we have a follow-up responsibility. So I'm just trying to figure out how they're going to figure out what's the follow-up and what's the initial, and this just muddied the waters greatly.
Gotcha.
So I'm like, I don't know if I need to flip to outpatient codes, and I mean, this just muddied it pretty good. Sorry, I'm just trying to process how to explain it to them too, because they have never allowed H2011 as a follow-up. Now I'm going to say you have to, but they're going to want to know how they figure it out.
And I do know, just from the CCO rate setting work we've been doing, the intent is that, I mean, the service is the same regardless of who you're providing it to. It's mobile crisis intervention services has the 72-hour window, follow-ups required, and the intent right now, the plan is to have billing for all CCOs follow this guide, which means they will have to adapt to this. And the intent, even if you're using APMs or other, not just kind of a strict fee-for-service encounter-based billing, that be sort of checked at the end of the year to see, just to make sure that CCOs are paying at least what you would have received if all the members were fee-for-service.
Yeah, and I don't know, because we're encounter-based for most of it, but because we've always done follow-ups within 48 hours, 7 days, and 30 days. We've always done that, but we've switched to the outpatient code, so it's clearly delineated. Here's H2011. Now we're going to switch over to the outpatient code, so it's clear to see the follow-up services. Right. So all I'm seeing is more reporting in my future, not my future, and options future, because we're going to have to tell them what we did versus them being able to pull it from claims. Because how are they going to be able to tell who started the follow-up stuff? So, this is going to be, I echo that, it's going to be, I don't even know if we can set this up in our EHR. Sorry, I'll quit lamenting, but yeah, that's okay. My question.
I appreciate you processing, or thinking through what it will look like, and we will, support as we can. Figuring it out. Beth, I know you had your hand up, and then maybe I've had some other questions to go through in the chat.
Yeah, there's a bunch. Well, Shelley, I just want to reassure you that those are the questions that the CCOs and the OHA are trying to make it as easy as possible. So there's not 5 different ways that you have to bill. So what Luke's saying is, behind the scenes, they are trying to figure out how to make it, universal as they can because of all the different payments. So hopefully
I just don't see how this is going to be done except through spreadsheet for some of it, and that just it just breaks my little heart there, because that's just even more administrative work if we don't have a way to separate this out. And then I'm looking at our AHR going, oh dear God, I don't even know if I can figure this out, how to do this, unless we drop to paper and kind of manually push some of this through. I don't know if other people are feeling a little overwhelmed with that, but
well,
I'm trying to literally have to figure out how to do this without dropping to paper again.
Well, hopefully, just remember also that MOTS for crisis is going away, and are redoing that entire MOTS system. And that system will capture some of the data and things, so it won't be duplication. So we can chat more later about some of the things that are going on and make sure. But I just want to remind people of that.
Yeah,
that
Rhodes
MOTS
is coming on, but it's my understanding it's not going to be on for a while, though. I at least I heard it's
Suppose-
probably not going to be September, but maybe my information's wrong.
No, so phase, well, and I don't want to hijack
No,
Luke's-
it's fine. Sorry, I'll be quiet. I'll be
I
quiet then.
will, so we are looking, and Rhodes is set for, I mean, we timelines, but yes, phase 1 is for MCIS, and that is set for December. So the timeline may get pushed, but December to align with starting MCIS, and then MRSS is looking at spring of 2024 to be the second phase rollout. We can talk more though, like I said, about all of that. I do want to just get a couple of these questions because they're really to Luke is, Luke, you know how when somebody has private insurance, we usually have to get a denial from private insurance in order to bill fee for service. Is that going to be the same thing? Because how would they do that in a crisis situation? So if a child has OHP secondary and they have primary first, do they have to go through all of those steps just like they do with other?
That's a great question.
Because it's crisis.
No, it's a great question. And I think let's for now add it to the list of questions we need to get back to you all on.
The next question is about sort of what Shelley was saying about switching to outpatient codes. If they have a contract with a private insurance, if they have a relationship with private insurance companies and a person they're serving, it has that private insurance, they follow the private insurance billing guide for that client and not this billing guidance for ours. Is that correct?
Yes, I mean, if it's not a Medicaid member, this guidance is not relevant.
Right. So if they want them to use specific codes and things to bill Providence or MODA or whoever that is, the agency should follow those protocols. Most of our CMHPs a lot of the CMHPs are not set up and don't meet the requirements and extra. So it's up to you. If you have a contract with them, you follow their billing for that individual, not the OHP billing. And then can you just clarify, so for non-MCIS crisis, do we bill H2011 without any modifiers? So they're using H2011 right now for mobile crisis, but they're also using it for other services, I think, is what she's talking about.
Yep. I'm just scrolling through the FAQ document real quick because I believe there's one that answers that. I'm just going to copy that in so you all have the text there, but again, check the FAQ. So H2011 is crisis intervention services per 15 minutes. It's not limited to mobile crisis. And when you bill H2011 with no modifier, it's going to pay at $39 per 15 minutes. The CG modifier is because if any of y'all saw the first draft of the billing guide, we had no modifier that indicated old standard mobile crisis. We did now just because we did want to, and this has to do with kind of like the CCO rate setting risk corridor piece. There is a need to set up to differentiate mobile crisis services from non-mobile crisis services, because most of the CCOs pay the CMHPs in an umbrella way for all crisis services, and that's going to change. They will have to be split out. So yes, you can use H2011 without the CG or HE or HT modifiers when you're rendering crisis services that are not mobile.
And then it just sounds like, and I think we got this feedback too, just people trying to wrap their head around how they're going to do this in their EHRs. And so I know that our BIS team is also reaching out and working with some of the agencies to try and figure out how to kind of switch over once Rhodes is up. But yes, you guys all have different EHRs and it does get tricky. But Luke, this question came up, and I know that we've talked about this, is that when you use multiple modifiers like we're doing, it gets tricky. And also, I think that this came up, several providers in our area have issues with billing two modifiers on separate claim lines. So I know somebody else had talked about having how many lines they do in the claims issue, and that it's very difficult for when you use two modifiers.
Mhm.
Anything to say about that?
Yeah, I know I don't recall which provider it was, but someone had emailed me a question. This is a month or so back, essentially indicating that they couldn't bill multiple lines on one claim. And I asked for more information just to understand that, because that was the first time I'd heard it. And I never got any follow-up. So for those of you that are in particular seeing a difficulty billing multiple lines on one claim, with each of those lines having different, for instance, modifier or place of service code listed, I would love additional information about that. Maybe if you could kind of write it up in an email, because that's a problem space that we've heard about, but I haven't gotten enough information to really do any problem solving with it yet. So I know that's a non-answer and more of just an ask for additional information from you all if you're facing that.
And then again, back to, and I know there's a couple, there's still more questions coming in. Again, just folks really trying to wrap their head around how they're going to do this in their EHRs. But also just to clarify, if somebody has private insurance, let me just make sure I find the right one. If a person has private insurance and DMAP, right, as secondary, so they use private insurance codes, then it goes to Medicaid. So they'd be using, so just bringing up again the complexity in, if they're going to bill private insurance, but they have to get a denial, they're going to be using different codes. And then how do we change those codes to then go back and bill fee for service, which is not, you know, sounds like that's really difficult, because you'd have to go in and change the codes after you got a denial or.
Sure. Yeah, I don't know if there's like a parallel with existing services. I'm just assuming that not all services match up one-to-one, you know, between like private insurance billing and Medicaid billing, whether it's fee for service or CCOs. But again, that's what I can follow up on and dig into, like the denial question, whether that's required, and what else would be required when you have to bill primary and secondary, and if there are different codes or modifier combinations to use for those two. So.
Yeah, the switching of the code seems like there's several. We'll have to go back and really dig into those in the question box here. I do have a question though around the CCBHCs. So if the CCBHC, would we bill the T1040 at the established PPS rate and then the H2011 with the applicable modifiers on the claim? Do you know how they separate out? Like, so that's for an agency that is a CCBHC.
Yeah, so I've worked with Katie Rosenthal, our CCBHC analyst, on this, and where we landed was that CCBHCs will bill their standard PPS rate. If I understand your question correctly, just because my understanding of CCBHC billing is really limited, I think you bill your PPS rate and then sort of do like you submit a claim that would have H2011 and the appropriate modifiers. That's not going to pay that rate, but that just sort of tells them what service was rendered. Is that?
So typically when we have to do our CCBHC billing, the T1040 code is required as line 1, and then the applicable service like the H2011 is on the second line. And so the T1040 pays at our PPS rate, and the other line is considered included in that PPS payment.
Yes. So that would be a yes. That's how you would do that.
Thank you.
And I'm just going to say this out loud and see if any of my coworkers can clarify, or Lauren, if you have anything to say, and maybe put it in the chat box. But can you just comment on the status of MOTS, and if MOTS is required right now and until Rhodes goes live, or are we still on a hold with MOTS while OHSU is stepping in? I think, Lauren, you can, if you know any of the answers to those, you can put in the chat box. Otherwise, Anne Marie, I will follow up with you after the the meeting.
Hey Beth, I don't honestly think I can put that in chat. So I'll
Okay,
just
great.
quickly state that I would much prefer that our BIS and roads colleagues be the ones to speak on this, but I can reiterate what I have seen in emails from them. We are not asking you to make any changes to your MOTS files. A lot of you have your MOTS files set up as EDI and you can continue to do so. We're not asking for any edits or changes to those. For further clarification on what's expected, please feel free to reach out to us. If you need that further clarification, we can connect you with those folks to get the same messaging across the board. I just don't want to speak out of turn.
Beth, I want to jump in just on one question I saw in the chat that you hadn't
Yeah.
raised yet, which was from Mary. And her question was, is it accurate that the HE modifier would be used if the crisis response is in a hospital or facility, no matter which credentials respond? But we would not use the HT modifier in this location, even if a QMHP was there for the duration of the response. Excuse me. So yeah, Mary, to your question, the rules, which again describe mobile crisis intervention services, do not speak to the location of the crisis. So yeah, if there's a little caveat in your question. You say no matter which credentials respond, as long as they're eligible providers fully trained to be on the mobile crisis intervention team, then the answer is yes. Doesn't matter if you respond to the emergency room or to some other facility, you can still bill MCIS at the higher rate. And to the second part of your question, yeah, even if you have a team of 2 QMHPs going out and they go to a hospital, you could still use HE and get the higher rate, but you would not use the HT modifier in that case. Any response to a hospital or facility setting would automatically exclude the HT modifier from being used.
Thank you. And so that would also exclude the follow-up as well, right? So
that's
okay.
Correct.
I just want to make sure. Thank you.
Yes.
I think one of the big things is that CMS now considers like sort of the first 72 hours, they're willing to pay an enhanced rate for all of the response you guys do from the beginning, from the call and when you go out all the way through that 72 hours. And so that's not an OHA decision, just to be clear, is that CMS has redefined what their crisis and what that looks like, which has changed sort of how we are looking at some of the billing stuff. I just want to comment, or Luke, there's one last question here is, when do they have to have this all rolled out and figured out in their EMRs? Because it is, people are, trying to figure out what the timeline is for them to start doing this.
Yeah, I'm just thinking of whether the certification application includes anything about just sort of having the technological infrastructure to actually do the record keeping and billing. But like, I mean, the billing guide actually calls out, you have to document according to, Medicaid documentation rules. So if your system can't support it, I don't know how you roll it out. So it seems like those two have to go together. And my understanding is that there's been communication. I mean, the rules are live right now, right? They were in effect as of January 1, but no providers are certified yet. And I think the intent that's been communicated is that 2023 is sort of a year for everybody to ramp up within that year. And I know some counties are closer than others on that. So that's the intent, is that we're figuring out these things now with the intent that I think the hope is that everyone's ready to go in at least by January 1, 2024. But Beth, you may know better than I do on this count, or Lauren, where exactly that stands. So.
No, I think that that's where we're at right now, is that there is an application process as of today that is needs to be completed, and that once the application process and you're approved for MCIS, that the counties then you guys, and then it would have to align with when you have the MCIS teams that meet the new higher enhanced standards. When those teams are ready to go, you guys can start billing at the $105 an hour, or 15 minutes, sorry, which is so you can start billing for those services once you have your certificate of approval and the green light, and you have the teams in place. All right, I think we're all caught up. Is there anyone though, can I just ask real quick, Luke, is there anyone's question that I didn't address some way? I know we don't have answers for a lot of this stuff right now, but did anyone's question not get answered? There was like 20 of them, so I tried to summarize or make sure I hit all the main points. Anyone feeling like I didn't address? Shelley?
So I'm sorry, this just popped in my head. So say we do a crisis service at the hospital, we'd build H2011 with no modifier. Then is there
You'd
any
use
problem?
the HE modifier.
The what?
You would use the HE modifier
Even though it's only one person at the
okay, sorry.
hospital?
If it's one person, no, yeah.
One person, one QMHP at the hospital, because we can't have non-QMHPs at the hospital.
Yeah.
Okay.
So is there any problem with just dropping to outpatient codes then to do the follow-up versus doing the H2011 CG? Because the other problem is a lot of times folks don't want follow-up because they've been there, and getting 15 minutes can be rather a challenge. So a lot of times we drop to the outpatient codes. So is that going to mess anything up in your statistics or timeline if we just keep our system in place for that?
Shelley, let me get through the stabilization services slide, because that really speaks to that transition from billing mobile crisis intervention services to billing outpatient codes under stabilization services. But I will say, if it's just a QMHP going to it, when you said at a hospital, is the QMHP going as a mobile unit to the hospital, or are they already?
We've always built it as mobile unit to the hospital. They have to leave our crisis, and our crisis unit go to the hospital, evaluate the person, and then we use it as a step down to our CRC if our crisis center, if they need to go over there.
Gotcha.
So it's one QMHP that goes.
Gotcha. That's helpful. Well, so let me jump. The next slide actually talks about mobile crisis billing for under the old standard, which essentially that's what you just described there, even if it's going into a hospital. So Brian, you want to jump to the next slide? So this indicates, providers not certified to render MCIS or not rendering MCIS as described in rule, which would be, like if you have just one QMHP going to address a crisis, whether it's hospital or anywhere else, that would be billed using H2011 with the CG modifier. And in those cases, you would not use the HE and HT modifiers. You're never going to have a claim with CG and HE or CG and HT. Those two sets are mutually exclusive. And then the list here of criteria for eligibility under payment are fairly standard things, but part of the Medicaid state plan as it relates to crisis and stabilization services. So the next slide, we'll talk briefly about place of service codes, and then we'll get to that stabilization services piece, Shelley, and hopefully dig into your question a little bit. So place of service codes, we want you to use 15, which is the place of service code for a mobile unit, unless there's some other OAR or guidance that would indicate otherwise. The one example that I have where it would supersede that would be a telehealth claim, and telehealth billing guidance currently requires you to use the 02 place of service code. So in that case, if it's a telehealth response, you're going to use 02 instead of 15. And then just because you may have in one initial crisis response, you may have both a telehealth and a in-person modality, you bill each of those modalities as a separate line on the claim. to apply the appropriate modifiers and place of service codes for each line. I'll pause there if there are any questions.
Can you just, Luke, clarify, when do they start? When do they start billing? Like, do you have to only be face-to-face with the client and only get to bill the face-to-face time? I believe in the documents it says this, if they, it's from the time they arrive on the scene until they leave the scene is the start and stop. But can you clarify?
Sure, yeah, the definition of initial crisis response that's in the billing guide is that it's from the time the MCIT arrives on scene or first makes contact with the individual, whichever is earlier. So if contact is made via phone or telehealth, that's when it would start, as opposed to when they first arrive on scene.
Can I ask a question about that?
Yes.
So we don't get to bill it if we get dispatched but then canceled halfway through. So like we get called from police to respond, and then we're on our way to the scene and they say, never mind, we're just taking them into custody, you know, whatever, you don't need to respond, or whatever the case may be, client is being taken to jail, something, whatever. We're not billing for that then? We don't get a bill for that time?
That's correct.
Okay.
Yeah, and that's what the kind of supplementary general funds are designed to help with, is just recognizing that even some of the times when you go out and actually do a full crisis response, there may be some scenario where you aren't able to bill. So whether it's, again, whether the call out gets canceled or it's somebody that does not have Medicaid coverage, or whatever the reason for it not being something you can bill, that is actually factored into the rate, not into the rate, but into the supplementary general funding.
I don't know if you could answer this or not, but would it still be part of our reporting? So all of our, we have to do the real D and all of the reporting for these of, you know, how many times did we get dispatched, all the different stuff. So would we still include it in our reporting even though we weren't able to bill it? Or do we only include billable services in our reporting?
Lauren, you may or may not know the answer, but I think we should get someone from the BIS team to speak to that specifically. I think we're going to want to know about all responses and not just those that are billable to Medicaid, but definitely want to get confirmation.
Yeah, Luke, I actually am the one who has to answer for that one. It is all services. It's not just billable services that we want all that data to be collected for.
And then in that case, Lauren, it might just be, might need an additional clarification on what, so even if it's not billable, but like, did a service actually happen? If you got called out, you know, went halfway and then turned around and you never actually can even ask the person any of the information that's normally supposed to be collected for a crisis response. So maybe something for further.
And all of that is already incorporated into the data. So there's an option for like, could not find the person, right, or canceled dispatch, or I can't remember the exact wording. So.
Okay, I just want to make sure it's clear that we're reporting on all mobile crisis for reporting purposes. It's every interaction, regardless of if it was a billable service, regardless if it was a Medicaid client, it's all mobile interactions for reporting purposes. It's only the billing side that then, so we have to just try to build that into our HR as well as all of these modifiers, which makes it super complicated. Just saying.
Yeah. Yeah. And well, I won't, yes. It sounds like it is very complicated, depending on the EMR that's in place. Yes.
Stacy, I see you got your hand up.
Yeah, I just want to be clear. So under the way you described the initial service or what's billable, we arrive on scene and let's say we meet a family member, but the individual of concern has heard we're coming and taken off and run away. We never meet that person, but we're working with the family for an hour. Under the way you just described it, we can still bill for that. Under the individual's insurance.
Yeah, so that's where it gets tricky. I would say it's, and I'm still kind of chasing this one down. If the individual is there and you're engaging with the family member, like say the individual is there, but you're not really able to productively engage, but you are working on stabilizing the crisis as a whole. That's a little bit different because the individuals there, you are still stabilizing them even as you're, or I mean, let me paint a different picture.
I mean, it happens, like, so we have an
Yeah.
individual barricaded in a room, they're there, we can't engage with them, they're not responding to us yelling through the door.
Right.
So
I'm gonna just take a look at 2 of the FAQ responses I've written up just to make sure I got it right. But
and sometimes they leave and the family still is in crisis themselves, but then it feels a little inappropriate to bill the person's insurance if they weren't there, but at the same time, we are providing a service and we need to pay for our teams, frankly. I mean, mobile crisis doesn't seem like a model that really works fee for service. Still that out there.
yes, I recognize how complicated this is from my perspective without actually like doing the work that you all are doing in terms of rendering the services, documenting it, and setting up the the HRs to do it. But yeah, this is, my slice on this is to come up with a guide and guidance that would explain how to bill it as a fee for
And I
service.
want to do it ethically too, is
Right.
why I'm asking this question, because
Sure.
it does feel, I wanted to bill for everything we can bill for. And I feel a little uncomfortable because the scenario you're given, it does sound like we can bill a person's insurance that's not even on site.
Yeah, and that's where I'll say that one, like, don't take that away from this, because that's a question we're still trying to answer, is when the individual is either not present or not engaged at all. My gut in general, just Medicaid perspective, is that if you're not rendering the service to the individual, you can't bill that individual's Medicaid for that. The one where I can offer some clarity is just from our FAQ document. The question says, during a crisis intervention, the MCIT will spend time with the individual in crisis, but may also need to speak to family members, law enforcement, or others present at the scene to gather information and stabilize the situation appropriately. Is the entire time spent on scene rendering the service billable? And the answer to that is yes. If the individual is engaged as appropriate and services are documented correctly, the entire time spent on scene rendering the service can be billed, even when you are spending, say you spent, like you said, an hour working with the family or others, or law enforcement, others that are there present. That's if the individual is present and engaged appropriately. So I can say, we would expect that in certain situations, you would spend time engaging with other sort of periphery members, not just directly with the individual, and that is billable. But the one of, if the individual is not present or will not engage, that's the one where we are still trying to tease that out and see if there's a way to bill it. But I would say the default at this point would be no, you cannot. But I'm chasing that one down to see if there is as you said, an ethical, appropriate way to bill that.
I appreciate that, because
and
the gray
Steve-
area. Oh, I just want to throw out, like, sometimes that non-engagement is because of symptoms and other things. And so sometimes non-engagement actually results in a director's custody hold because the person's unable to engage, like they're not in our reality, catatonia, so involved in psychosis. And so I'm not trying to be like super difficult, but I want you to understand the nuances of what we're gonna have to figure out here. And the more clarity we can get, the better, because sometimes not engaged is, I don't want to talk to you, goodbye. And sometimes not engaged is, I'm not capable. And we're still providing clinical services in all of those things. But when you're doing services that are not voluntary, involuntary services, it gets really difficult to determine billing
For
when the
sure.
person didn't invite you into their space.
Yep. That makes
Stacey, I was just going to agree that there's a ton of clinical sort of that you have to rely on your clinical expertise. And sometimes someone not engaging with you is part of your clinical assessment of that person. And that also, it even gets even more nuanced when you're talking about an adult versus a child, who's locked in their room and you're working for 3 hours with the family and talking through the door to get the child de-escalated while also coming up with like clinical plans with the parents, how we're going to support. And so there is a lot of clinical judgment in those, just like with any sort of interaction. So I just appreciate you thinking through all of those different lenses. I think Angela's hand went up, Luke.
Yeah, let's take Angela's question, and then I do want to make sure we talk about stabilization services too while we still have some time. So
Yeah, I was just curious. So are you going to have some sort of guidance, especially means we're going to have QMHA level staff, not necessarily always P, making these decisions. And I think it's really hard, means we're allowing peers and QMHAs to provide these crisis services. And I need to have some really clear documentation and understanding of when are we considering that the client was present and able to be engaged in that service and we can bill for it versus not, because especially with measure 115 additional, children are going to be covered a lot longer. We're going to have, we should be providing these services, and especially for children and teens, a lot of times you're not interacting with them directly because they're not willing to interact with you, and you're interacting with the family and getting the history and doing all this stuff, and you have very little interaction with them. But maybe that's also what makes you decide they're appropriate for a hold, because they're not doing, they're not de-escalating in any way. So just any documentation we can get from the state on that, so that we have clear guidance for our QMHA and peer level staff that are often going to be the ones out on scene. Not that we don't have Ps, of course, that they can reach out to, but I just would love to have some more guidance on that. So.
yeah, I think, and Beth, maybe from the clinical perspective, you can correct me if I'm wrong, but I think like we want to be clear from the billing side what's billable. And my hope was, I know we have further questions to answer, but my hope was that like what's in the FAQ there would be the clear enough guidance. And it feels to me like there's a layer where the QMHP or mobile crisis team lead, like that there is, just because like we're not going to be on the ground for every clinical situation, there will only be essentially we'll have to figure out how to get as clear as we can about what we can be clear about, knowing that there is going to be like for you all on the ground having to think through individual situations and what sort of how you work that up as a team in terms of clinically what's just that clinical judgment piece that we can't speak to. So that's just me, sorry, wrestling out loud with how do we spell out what we can without going too far and actually like stepping into a space that is yours. So anyways, we'll sort that out, and I appreciate the.
Yeah, just something that even, if it's, you're having interaction, but it's not that lack of interaction is what is making you determine this person, like something that's spelled out, even that says that in it. It's like, okay, well, so that we have some sort of backing when we write in the note that we never spoke to the client, like, or we spoke to them, but they never retrieved, right? They never returned that communication. I just want to make sure from an audit perspective that they're not going to go, well, why did you bill this service? It wouldn't be billable. You never had interaction with the client directly. So that's where I want it spelled out as much as possible, so that we have that backing when it comes to audit perspectives.
Gotcha. And yeah, I will say, if, for instance, say the documentation was left the way it was, or as we continue to answer questions, I would say things that we're not specific on like that, we would be leaving to your clinical judgment. But yeah, I appreciate the thought of making sure how do you document appropriately, bill appropriately, not just to follow the rules that are published, as well as to get through an audit when that happens. So yeah.
I guess the only other part of that is hopefully maybe the billing side and the reporting, because it sounds like we're going to be reporting everything. So if you guys are seeing that we're having to report a lot of things that are not billable, hopefully there'll be some further discussion on what does that mean and what are we really looking at rate wise? Are we really capturing the level of effort that we're having to put in versus that's hopefully going to be captured in all of our reporting versus what we are actually able to bill for? If we're only able to bill for 25% of the interactions, that we're having, I hope that that's evaluated and reflected in future.
Yeah, absolutely. There's, I will say, like, the rate was set with as much information as the agency could gather, and our contractor, Optimist, who was doing the actuarial work with that. But again, it was so apples to oranges with the existing service. It was really hard to get good data on exactly what the utilization would be, what what sort of like the productivity rate would be, how much of in an 8-hour shift or something would be billable time, what percentage of encounters would actually be billable. So as we start to collect data, if it's identified that there is a significant gap between the rate that was set and how it's working out practically speaking, again, we from the fee for service side always want to ensure that rates are appropriate, and that is obviously an ongoing process of assessing and reassessing and seeing what needs to be changed if something does. So yeah, that data collection piece will be really crucial to make sure that the rates support the service appropriately.
And Luke and Angela, I appreciate everything. And we all know that, like, we're trying to wrap our heads around how much these services really are going to cost. And so I just encourage you guys to continue making sure you're checking in with whoever your representative is for CMHPs that are in the work groups. Because we did do 11 million in one-time funding, and we do have service element general funds that are coming through for MCIS, and then another 18 million just for stabilization services. That's, I know, gets divided across all of the counties, but also thinking about what is the gap between what we're giving you in those services and in this new rate. We won't actually know the gap until we get some of the data, and that your CMHPs are also promoting other legislation to help bridge that gap as well. So totally understand and appreciate you guys, thinking about how to do the billing and recognizing that we did give some supplemental funds. We just don't know what the gap is going to be and what we were able to provide versus what the reality is. But we'll be that's why we're tracking it all. So appreciate you guys.
Brian, can you jump to the next slide, and we'll get into stabilization services with our last 15 minutes here. So billing for, as you guys know, in the 309-072 rules, that there's like, it's whatever the numbers are. The first several sections are just on mobile crisis intervention services, and the last one, which is 309-072-0160, is stabilization services. Again, similarly, before you render, you need to be certified through the process that licensing and certification is outlined to have stabilization services added to your COA. And essentially, if additional services are needed for an individual who's experienced a crisis like this, if they're needed after the end of that 72-hour window that you can render MCIS in, that's when you would engage the person in stabilization services. Next slide, Brian. So billing for stabilization services, the kind of the basic framework for it is to use the appropriate outpatient procedure codes from the behavioral health fee schedule. We heard in an earlier version of this, folks were asking if they could continue to bill H2011 after the 72-hour period for stabilization services, just recognizing that the sort of enrollment process for stabilization services that's outlined in rule requires a mental health assessment and service plan, largely because that is required to bill most outpatient codes. So if something holds that process up, as rules indicate, if the person needs services after 72 hours, you're supposed to transition them into stabilization services. If something holds up that MHA or service plan, you can and should bill using H2011 as stabilization services are needed. If you do have to use H2011 to bill stabilization services, you just need to complete the MHA and service plan as soon as possible. So that's designed to give you all a little bit of flexibility to bill H2011 as needed if that's sort of those intake pieces that are supposed to happen are delayed for one reason or another. We've heard, the availability of QHPs. We've heard, in some cases, the family themselves might not be willing or able to engage within that time frame. I'll also say, just by way of reminder, stabilization services are required to be provided for children and their families. So across the state, this needs to be stood up at least for children and their families. They can be provided to everyone else, but you're only required to provide them for kids and their families. And then again, this is just getting down to an informational modifier, but when you are rendering stabilization services to youth and their families, whether you're billing outpatient codes or H2011, you'll use the TS modifier. That just flags it for us to say, this is stabilization services rendered to youth and their families. And if you're billing H2011 for stabilization services, you wouldn't use HE, HT, or CG, because those are all specific to mobile crisis or MCIS, as opposed to stabilization services. So I know, Shelley, you had several questions about that transition from billing H2011 for mobile crisis to billing outpatient codes. I don't know if what I just said about stabilization services helps clarify that at all, but happy to revisit that with you now, or for anyone else who may have questions on stabilization services.
I think I got to think about this a little bit before
Sure.
sorry.
No, that's fine. I didn't mean to put you on the spot. Take your time.
No, I don't mind at all. It's just, I try to, when I think about it, I try to wrap it in our system. Like, okay, how do we do this?
Yeah, and I just wanted to clarify, just a small clarification, is that not all youth who are seen in a crisis are going to need stabilization services. Many of the youth and young adults that you guys see already have services in place. And so your job will be in that 72 hours, right, to de-escalate the initial crisis response and then to do some follow-up to get them maybe back in contact with their prescriber or back to whoever their service delivery person is. Stabilization services just have to be available. So you have to have a system in place to be able to assess the youth and see if this would be an appropriate next step for them. So again, not all youth will be entered into stabilization services.
Okay, that was part of my question. So if they're already open, or if we can get like the mental health assessment done like the next day, they don't necessarily need stabilization because we roll them right into outpatient.
Yeah, so yeah, if you have if you can, for those programs that have IIBHT, we ask that once they're referred to IIBHT, they have 3 days to do an intake. So like if you have a youth that's out, you go out for a crisis, they're not known to you, they are struggling, maybe they were an outpatient 6 months ago, but they haven't had any services. You guys assess, you might just make a referral straight to IIBHT. Don't enroll them in stabilization services. Like you may need to do a quick mental health assessment and then assess and make sure they meet criteria. But some of you guys have that's the whole vision of MRSS, is that we're getting out there and we're connecting people back to their services and helping them reconnect to keep them out of the emergency room. But if there's youth that we might need a couple of weeks to assess what's going on, and maybe it's not mental health, maybe they don't need outpatient or something else, or maybe their current services aren't enough. So we really just want to think about stabilization services as helping to stabilize while getting them into their next services, whether those are mental health services, or maybe the family just needs some help re-engaging with the school, or getting the youth enrolled, or needs help getting, whatever the social determinants of health are that might be impacting the family. So
okay, so we don't have to put them into that 56 days if we can just do the IIBHT, because I was actually, what I was thinking is getting a service connection to the IIBHT or ESA, whichever is appropriate, as fast as possible, and then really not doing as much of the stabilization.
Yes, Shelley, if you can do that. So like, let's say,
well, I don't know, it's a dream.
Well, and so here's my thing, and I just want people to be wrapping their head around, there is eligibility criteria. It is very, very general. We want to be able to help these families. So say you have a child that you guys go out for a call, and this child is maybe had services or doesn't have services, but the family's really struggling, and you need to you want to wrap your head around it. You could enroll that child and family into stabilization services. That gives you up to 56 days to work with them, really assess what's going on. And if you decide you want to make a referral to ESA and that this child has psychosis, you're also helping to keep them out of the emergency room while you're waiting to get that intake with ESA. So thinking about it being bridge services, just like our CATS program was for really high intense situations. Are we trying to get them new services, different services, or is our job just to connect them back to existing services, which means we would probably not open them?
And Beth, I just dropped the answer from the FAQ, or a question and answer from the FAQ into the chat. It actually, to me, sounds a little bit different than what you just described. So I kind of put it in there to say, like, let's you and I make sure that it says what it needs to say.
Sure.
So, because the question was essentially, if someone's already engaged in outpatient, how do you know whether you bill, use the TS modifier or just continue? And I indicated if they are receiving, if you're just continuing the same services that they were already in, it would not be stabilization services. If you engage in any new services as a result of the crisis, that would be stabilization services, and you would bill the TS modifier. It sounds like there's some gray area there, and that, like, because of the crisis, you might push them towards IBHT or some other type, in that it might change their outpatient services they receive as a result of the crisis, and that might not be stabilization services. So anyways, for you all, I think take what Beth just said, and we will make sure to follow up and clarify in the FAQ to make sure we've gotten down to the detail level we need on that one.
Well, and just, most outpatients don't have crisis. Most outpatients, people who are in outpatient, we tell them to call mobile crisis response if there's an emergency. If that family is popping up in mobile crisis response, is outpatient enough for them? If it's not enough, we would then enroll them in stabilization services, continue to assess, and maybe bump them up to a higher level of service, or maybe you guys would help bridge that gap back. So there could be some gray area in that. But I don't want you guys, it's like each case you would assess. And we can talk more on the learning collaborative too, because MRSS, I think we think about the hardest of the hardest kids that we're used to getting calls for. And MRSS is really starting to think about how do we get in front of and identify families that haven't had services and are just starting to bubble up in the community. So it's going to be a big shift for us, but we can talk about that in the learning collaborative.
And Beth, I did see a question from Barb asking if we can bill stabilization services for adults as well. The answer is yes, you can. That option, again, no CMHPs are required to offer stabilization services to adults, but you certainly can. And if you provide the services, then you can bill for them as well. If you do, it's just you would bill exactly as described here. It's just you would not use the TS modifier to call out that it was provided to youth and their families. You would just bill H2011 or the outpatient codes as indicated here. Yeah.
And just to clarify too, I think a lot of people ask us, why is this just for children? And just to reiterate that mobile response and stabilization services is a national model for youth that's used across the nation. And that we also, the Child and Family Behavioral Health Unit, also earmarked 18 million in funding to be able to offer this to any youth in our community that needs stabilization services, not just for OHP. And that's a new service element. If you don't know, it's 25A. Angela, I see Angela's hand, but also Luke, I lost track of the chat box because I know we're right at time here.
Yes, we are. I'm just trying to swing through real quick to see if there's any.
I did want to just, Lauren's hands up, and just to clarify is that the reporting requirements for stabilization services is just for 20 and under. It is not required. You do not have to do the pre and the post. You do not have to do the Ohio scales for adults. They're not actually even aged for those. They're aged, they have age requirements on them. So all of the MRSS reporting that we're doing for stabilization services that's above and beyond is for the 20 and under.
Beth, one other question that I just see from Mary that seems helpful to raise is the connection between MCIS and stabilization services. So her scenario is if there's a youth in crisis, but only one QMHP responds. So it's essentially like old standard mobile crisis. Is stabilization services required to be provided if the youth needs it? Or does stabilization services, is it only required if it follows after a provider who's rendering MCIS? You're muted.
I'll have to look at that more in depth, and I kind of got lost in it. I mean,
Yeah.
basically stabilization services are like when we're talking about stabilization services, it's anything that happens post 72 hours, ideally.
Yeah.
So anything that happens in the 71st initial response in 72 hours as part of this mobile crisis, and then the child would move to stabilization services, use outpatient codes after that, because you can't, we don't get advanced or enhanced rates after 72 hours.
But if the crisis response, it doesn't fall under MCIS, where we only have one staff responding to it, and we have to bill under the old or the CG modifier, do we pursue stabilization services for those folks that we're not initially billing MCIS for?
Beth, I feel like
Mary.
regardless of the type of mobile crisis, stabilization services is a separate service and is required regardless of the type of mobile crisis that you're able to provide.
But I see, to Mary's question, there may be some nuance there we have to address around the 72-hour window, which doesn't exist for old standard mobile crisis. We're also at time. I thank you all so much. I appreciate you being here. I know we've had some of these conversations before, and we will continue to do our best to bring as much clarity to this process and this complicated service. And yeah, just want to honor you all for the hard work you do for your communities. And we will do our best to continue to partner with you to get this working as well as it can. Thanks, and hope you have a good day. And make sure you drop your email in the chat if you want copies of the recording or the presentation, and feel free to reach out to me with additional questions for us to answer. Thanks.